Okay, up next to start with, we have Dr. Sam Manger, whose bio I cannot find. There we go. Sam is a general practitioner and a fellow with the Royal Australian College of General Practitioners, where he received an award last year and where he received an award for the highest score obtained in his fellowship examinations. He's a president and a fellow of the Australian Society of Lifestyle Medicine, and also a senior lecturer and medical educator with James Cook University College of Medicine and Dentistry, a vocational medical officer with the Queensland Health, and a host of the GP Show podcast. Last year, the Royal Australian College of GP in Queensland awarded him GP of the Year, which is a wonderful achievement. In his spare time, he studies and practices functional movement, martial arts, Wim Hof technique, permaculture and bush survival. Welcome to the podium, Sam Manger. I probably got some of those words wrong.
No, that's all good, thank you. Cheers. Hello everyone, lovely to be here, thank you. Let me just see if I can control my slides. I can, great. There you go, technical glitches gone. So it's a real pleasure to be here, and hello to everyone online. I'm Sam Manger, that was my intro. I'm also the academic lead for the postgraduate suite at James Cook University for the lifestyle medicine courses, so Master's, Graduate Diploma, Grad Cert. So if you're interested, come and study. I've condensed about 4,000 slides into 40 slides, so let's see how I go, and I'm going to set myself a timer. But really, of course, like many, I would like to acknowledge traditional custodians of the land, the Ugambo language region, and where I herald from, which is the Gubbi Gubbi land in Sunshine Coast hinterland, and pay my respects to the elders past, present, and emerging. Oh, it's right there. That's good. I don't have to look around. I have no financial conflict of interest. I'm pro bono president of ASLM. I'm not paid to be here, though. Thank you equally well for paying for my accommodation last night. Much appreciated. And of course, just thank you equally well. I'm one of their ambassadors, like Andrew and Simon and many of the other sort of great people in this movement. So it's an honour to be so and to work with Malcolm and Russell and Dave in this field. So what is lifestyle medicine? Well, lifestyle medicine is what it sounds like. It's the use of lifestyle as medicine. So mind-body practices like meditation, breath work, mindfulness, and various other techniques, autogenic training, etc. Nutrition and diet, physical activity and movement, sleep quality and quantity, reducing harmful substances in connection with each other and connection with nature. But that's not enough, because no matter how good an individual practitioner is, whether they're knowledgeable in that area, that's never going to be enough. So there needs to be a behaviour change approach. There needs to be health coaching training and skills involved in the idea of behavioural science, behavioural insight, using built environments and modifying those accordingly, and the models of care, implementation science. How do we actually deliver this? Because no matter how good I may be as a practitioner, sitting in my GP room working for 15 minutes per consult, the system itself is limiting me so much that I feel I can only ever be about 10 to 20% as good as I can be. So we need to deliver lifestyle medicine effectively, we need to be able to really seriously look at the models, which we've already, I'm sure, already talked about, but more than ever for this field in particular. And then, of course, technology and research that's personally and culturally adapted. This is a lifestyle medicine model of disease put forward by Professor Gary Egger about 10 odd years ago. And really it just highlights the point that we really focus on the determinants or the root causes. So I think I've got a laser pointer. So obviously when it looks to mental health, we've got depression, dementia and anxiety and many other sort of syndromic or ways we explain these via their symptoms, manifestations. And then if we actually look at some of the markers in research, we can see things like neurogenesis factors, neuronal damage, neural inflammation, microbiome effects, oxidative stress, etc. But what I really am interested in is the causal factors, the diet, the activity, the smoke, the sleep, the proximal factors, and then as Reza said, of course, those social factors. Socio-cultural factors, environmental factors and political factors, and we're really trying to change the healthcare system so we can evolve it so that lifestyle medicine is really genuinely first line, not just tokenistically mentioned, to change here so that we can drive and lead and lobby change at the social level. So in 2020/21, the Royal Australian New Zealand College of Psychiatrists released their up-to-date mood disorder guidelines, and here they put lifestyle interventions as essentially first line. So non-negotiable and to be discussed with all patients. So it's certainly back now, and the question is why? What's the evidence for that? So we're going to go through some of the each of those domains and look at the evidence for them. And of course, as was mentioned by Christine, oh yes, Christine's still here. It's not just mental health, we're talking about physical health. These things luckily benefit both, and they also improve social health because of obvious things like social connection. So let's go through each of these domains. I start with the mind first, or mental well-being practices such as meditation or relaxation training practice, progressive muscle relaxation, yoga, autogenic training, and there are many. Partly because the mind, as we know, we're all here, we're all usually mental health workers, sits at the core of so many other behaviours. You know, if there's disturbance there, it's very hard to work at a behaviour change level. So relaxation training, and you're going to see I'm going to cite as many meta-analyses and systematic reviews as I can, has a medium to large effect. So Cohen's D is a statistical effect size that we use. So Cohen's D of 0.2 is small effect, 0.5 is moderate effect, 0.8 is large effect. Most antidepressants, keeping in mind that's across the spectrum, have a Cohen's D of about 0.35 for comparison. Now that's much less for mild to moderate depression and much more for severe depression, but on average. So you can see here that relaxation practices for anxiety is actually very effective, and those who do it do. What's the mechanism of this? So this is a busy slide, but I'm going to break it down to three things. So bio, psycho, or social stress affects the brain in many ways. Partly, and I'll highlight one of these in the next slide, but is this production and creation and perpetuation of neuroinflammation. So the microglia, which make up 15% of the brain cells, they're derivatives of our white cells, the macrophages. So their job is to regulate the immune function of the brain. Their job is to clean the brain, remove debris, the metabolites, and that sort of stuff. When they're exposed to constant stress, they actually switch phenotype and they become pro-inflammatory, and they actually cause inflammation within the neural synapses. What does that do? Well, that reduces, that creates neural damage, but it also reduces neurogenesis, meaning less neurons, less wiring. So if you think about it, you've got a person you get antidepressants to and you're doing psychotherapy for, but if they're under this high level of stress all the time, their brain is inhibited to rewire and refire. So we can't, you know, all those things they'll be resistant to treatment largely. What this great study looked at, which was released in 2019, was the actual impact of stress on the neurotransmitter function and release. And what they showed, and this is psychological stress, social stress, or physical stress, is when you have this neuroinflammation occurring, what you see is a reduction in the production of neurotransmitters, the release of neurotransmitters, and the increased uptake of neurotransmitters. So what does that mean? Well, we all know what that means. Less serotonin, less dopamine, less oxytocin, less noradrenaline, which leads to various manifestations and symptoms of mental illness. So this is actually where I worked as a vocational medical officer or as a consultant, as a GIPSy, what we call them in Queensland, GP Special Interest in Psychiatry, in Sunshine Coast at the CCU there. And we actually set up a whole space for these practices. And one of the ways we used this was when people were distressed and they wanted some medication, some Valium, we would actually recommend they go to this room first. We had guided meditations, we had yoga, all kinds of things, and we actually saw about an 80% reduction in the PRN med use. Thank you. And so let's move it on. I've already taken a lot more time than I was hoping to, so I'm going to speed through these slides. But we know that movement, I mean, we've already talked about it, and Reza and many others have touched on it, I'm sure you have already, but we know that movement, and it's beautiful. I mean, there was a lot of groaning during that session of stretching, and I was a bit disappointed, because experiencing your body and mind is one of the great, great pleasures of life. And I encourage everyone to just sink into it and feel it. Moving is as effective as antidepressants and psychotherapy. It's not an optional bonus little thing that we should maybe add on top if we've got time for it. It is fundamentally crucial for mental health care. It's across the board, whether it's quality of life, mental health, physical health, and pretty much every disorder. What's the mechanism? Well, it's very similar to what I showed you for stress. We have almost every repair mechanism switches on when we are physically active. There used to be this idea that the reason we get a post-exercise high was the release of endorphins, which are endogenous morphines. But now actually we're looking more at what the endocannabinoid system is, and some of you would have heard of that. But it's actually one of the oldest communication mechanisms in the body. It's 500 million years old, this evolutionary system, the endocannabinoid system. It's older than the dinosaurs, I say to my son, so his eyes go, you know, when I say that. And, but it's a meta system, meaning it over and regulates a lot of the other systems. It affects neurotransmitter release, neurogenesis, the health of neurons, so to speak, with the neurotrophic factors, lower stress, reactive and stress responses like the hypothalamic pituitary axis. So this is, again, multi-domain effects. Food and mood is so important as well. The research here isn't quite as strong, but still strong all the same. Felice Jacker did one of the first randomized control trials here, showing that 32% of people who went on a Mediterranean diet with moderate to severe depression, so not mild depression, moderate to severe depression, went into remission versus 8% of control. So a third of people with diet alone, anti-inflammatory diet. This is backed up by a meta-analysis a couple of years ago, showing with over 45,000 people, showing a very similar thing. What are the mechanisms? Again, similar mechanisms. We're not talking about one receptor or one cell or one target here. We're talking about one intervention that has many, many effects. So with diet, we can look, I can't see, I've got the wrong glasses on, but we can see the hypothalamic pituitary axis, I think that was right, yep, being down-regulated. So that's obviously one of the main connections between our brain and our body. So if that gets down-regulated in the sense of the stress response, we get less cortisol, less stress hormones, less adrenaline, etc. Improved neurogenesis and brain-derived neurotrophic factors, reduced oxidative stress, anti-inflammatory diets. Food can be anti-inflammatory and pro-inflammatory. We take medication all the time, Nurofen and Advil and all these things to reduce inflammation, and yet we're eating food 3 times a day that is perpetuating inflammation. That doesn't just make us stiff and sore in the joints, that makes us depressed. So this is something that really does matter. And then, of course, the microbiome and its effects there, which we're only really just touching on. Here's some of the work on the left there, well, on my left, or on your left, is Dr. Linda Barron, who's a consultant psychiatrist who I worked with for about 4 or 5 years as the Gypsy. And here's some of the food we did, and I'll talk about that a little bit later. But one of the interventions we did at this ward was, luckily, one of the mental health nurses, Scotty, was an ex-chef. So he actually taught the service users, the consumers, how to cook, and we all actually had a big staff and a client lunch together every week, and I do a little education talk beforehand. So sleep and mental illness, the prevalence of sleep disorders is so high. It's 40% on average, but in some studies of people with schizophrenia, it's up to 80% of them have a sleep disorder. And again, we just cannot miss this. I've seen so many patients in my Gypsy clinic where people are coming in and they're sedate and fatigued, and it's thought that it's the clozapine, it's thought that it's the olanzapine or just poor lifestyle or whatever it is. But it's not, it's a sleep disorder. And you treat that sleep disorder and they wake up and now they have the energy to exercise and engage and their mental health improves. So it's associated with treatment resistance, it's associated with pretty much every stage of depression or relapse. What happens, again, if we look at the meta-analyses here of randomized control trials, so good level quality data here, that for people with mental health problems, sleep interventions, so non-pharmaceutical sleep interventions, and there are many, had a large effect. So again, that Cohen's D, 0.81. So that's 2 to 3 times as effective as an antidepressant on average. And the mechanisms here, they're not soft measures. These are not, oh, it feels good, I wake up a bit fresh. Why do we wake up feeling so much better? Well, one of the answers to that is what's called the glymphatic system. The glymphatic system is like our lymphatic system, but it's in the brain. It clears debris and metabolites that have been produced during the day, and hence we wake up and our brain has literally had a clean. But that glymphatic system is only on really when we sleep. One of its other jobs is to clean up those metabolites, meaning beta amyloid, which leads to dementia, sorry. 15% of dementia is thought to be due to sleep disorders. And then sleep as well has many effects, but immune system, obviously, it helps regulate our immune system. Social connection. In 2010, there was meta-analysis done on 300,000 people showing there's a 50% increased likelihood of survival for those participants in stronger social relationships. Roughly about the same as smoking a pack to 15 a day, which is huge. Other people have done other studies showing that it's actually the #1 determinant of such things. And again, this has neurobiological basis. Bereavement or social isolation or rejection, again, switches on this threat and stress response of the system, which I've already just very lightly covered. That also switches off what's the prefrontal cortex, which is our future thinking, planning part, which is like good to get. But that largely switches off the regulation to the limbic system, which is our emotional reactive component. So what happens is we get this down cascade again. We got the brain saying, we're alone, this is not good, we are under threat, right? And then that goes to the body, it sends the inflammatory signals to the body through the sympathetic nervous system and the pituitary axis. And then the body says, uh-oh, the brain's unhappy, we're in stress. Then that sends further signals back to the brain going, you're in stress, and on the cycle perpetuates. So we need to be able to interrupt and intervene on this cycle. And it sounds soft, but you know, it really does matter. There was a great 2020 paper here done by the American Journal of Psychiatry, looking at the sort of risk factor association. What they concluded was the impact of trusted social connections was causally protective for depression, and it showed the strongest phenotypic association. So really, trusted social connection was the strongest protective factor for depression. Again, these are not soft things. Which comes first? The obvious question is, well, doesn't depression lead to social isolation? Yeah, absolutely it does. It goes both ways. But when they looked at this was a New Zealand study done, I think, in 2018. I can't actually read the fine print there, but the social connections was found to be a stronger predictor, a more consistent predictor of mental health rather than the other way around. And connection with the natural world, which I think we have, and as Tom said, I think there's a huge amount we can learn from our Aboriginal cousins and brothers and sisters and elders here, because that is inherent in their definitions of social and emotional well-being, whereas us, it's somewhat disconnected, and we definitely need to reconnect back with the natural world. The studies here are not as strong for sure, but the studies that have been done look at the overall effect size, again, for improved self-esteem and mood. You can see here about 0.46, 0.5. And when they've actually done social return of investment studies, aka health economic studies, for every pound invested in getting people to interact with nature, there's about a £7 return because of their return to work and other benefits. Here's some work that I've done on this front. So on the right is obviously me, and on the left is Dan, who was one of the Aboriginal health workers when I worked at Pangula Manamurna in Bowen Digland in South Australia. And one of the interventions we did actually, because we talked to the community, as is, you know, the right thing to do, we know through co-design, we talked to the community and said, what was it, you know, you would like us, or what do you need from your health service? And surprisingly, the answer was not, you know, more doctors, more nurses, more money. It was a space for us. We want a space. And the whole outside of this Aboriginal Health Centre, it had an Aboriginal flag, so you could tell it was an Aboriginal Health Centre. But apart from that, it was a very Western. There was like square cut bushes and rosemary plants, and it was very, you know, disconnected, as it were. So we sought funding, and we got a small amount of funding, and we built about a 300 square metre garden with the elders picked the plants. We had medicinal plants, cultural plants, and a raft of other plants. The community, the men's group, the women's group, we planted it out together. We spent our weekends doing it. And this is just a, you know, a poor photo, but it'll do its job. And on the right was a veggie patch that we built for educational reasons. And then we had an open day, and the whole community came, and they put their hands in paint and then put them along that wall that you can see there, so that was part of their story now. And this is still there. That was probably 10 years ago. But the point is that we saw this massive engagement suddenly with the health service. Suddenly it was their health service. Their story was part of it. And so that reconnection and using things, sometimes health is not just about pills. It's about how do we reconnect people together. So smoking, we all know smoking's bad, but when it comes to mental health particularly, there's been systematic reviews here showing that smoking reduction is, again, seems to be as effective as antidepressant therapy in improving symptoms. Now, obviously, there's a 2-week hate period where no one's happy for 2 weeks when they quit smoking, but after that, things do get better. And we also know that, obviously, it's a risk factor for suicide. We know that it metabolizes medication, but I know you know that, so I'm not going to go through that. So that's mental health, and we all know about the physical health benefits. Christine said, I agree, we don't need to review the horrible stats here, but the 15 to 20 year life expectancy gap. But most of that health expectancy gap is because of physical illness like COPD, cardiovascular disease, and diabetes. 80% of diabetes is reversible with lifestyle interventions. Reversible, not with medication. 98% of people with diabetes are on medication. We have it the wrong way around. Heart disease is reversible. Not slowable, reversible. There will be randomized controlled trials showing that with lifestyle interventions. So these are things that really, really can make a difference. This is an old study from the Archives of Internal Medicine, just again showing prevention, 90% of diabetes preventable, 80% of heart disease. Sorry, do you want to take a photo? And all this adds up. The point is that this is a very effective therapy. Hopefully you've seen that now. It's very acceptable. It's very desired. We ran a survey with my colleagues at Monash with 1,600 people. 600 of those had a diagnosed mental illness condition. And 81% wanted lifestyle medicine as a part of the thing. 19% wanted medication as a part of their treatment. So it's acceptable. It's desired. It's certainly been my case. I have a 6-week waiting list because people want this kind of care. They're safe. It's extremely safe. And we know the mechanisms of action. This is a photo one of my patients gave me a little thank you card, which is beautiful. But some of the interventions that they had taken in from these points. And yes, we got to de-prescribe them, which is a beautiful thing. So how do we connect these to the patients? I've got 2 minutes to summarise models of care. I thought this would happen. Sorry, Malcolm. Sorry, Dave. But whether it's primary, tertiary, or community care, of which I've worked in all of them, it's very hard. But the reality is that it's not actually being delivered. Over 65% of consults, or GP consults, end with a script. Less than 4% of GP consults end with a lifestyle prescription on diet or exercise. It's not happening, right? If you think you're sending people back to your GPs for that kind of care, it's not happening. Most of the time, there are some phenomenally amazing GPs out there who do it. But the reality is that the system, these 15-minute, 12-minute appointments where we're dealing with 4+ problems per problem, it's just unsurmountable. And considering now that almost half of GPs are either burnt out or have a mental health condition themselves, that's likely underreported. This is a system that everyone is struggling in. And good on us, though. I mean, the Productivity Commission said in 2017, despite the messy suite of payments that are largely accomplices of illness rather than wellness, only countered by the ingenuity and ethical beliefs of providers to swim against the current. So well done us. We are really the only reason that this thing is still sailing. But it's going to be a case that we actually need some serious systemic change coming up, which, of course, all of you are talking about. So the question is, do we need new models? Do we need to deliver care differently? I mean, drill presses are wonderful for certain jobs. Medication, surgery do their job. They're life-saving, life-improving. But most of the time, you don't need them. You need a screwdriver or a hammer. And I can't help but wonder, when I graduated about 12 years ago, and I think that, we just jumped onto this treadmill that my seniors are running, and now I'm just running the same treadmill, but instead we've got the speed going as fast as we can, and I'm sweating, we're all sweating and we're fatiguing. We cannot run this thing anymore. We need serious change and implementation at different levels. We need lifestyle medicine to be embedded as an individual level. We need health coaching, peer support workers and health coaches brought in, link workers. We need behaviour change taught properly. We need clinical and community models of care, proactive models of care that can deliver to communities, schools, workplaces, civic communities. And of course, we need to change the social models. My colleagues and I are just about to submit we're very proud of it, a clinical guideline with the World Federation of Societies in Biological Psychiatry. First clinical guideline for lifestyle medicine and major depression disorder. And this is one of the graphs, the picture. I'm not allowed to, there's my 20 minutes, so I'm going to wrap up quite quickly. We are submitting this next week, but I was given permission to share this picture because I like it and I designed it. But it's talking about, it's a reverse Swiss cheese model of lifestyle medicine. The point is that if we have multiple layers, diet, physical activity, stress, smoking, health coaches, peer support workers, is that we're going to catch people before they deteriorate. This is not a one sort of dimensional intervention. And there's so many ways, like I said, health support, link workers that use in the NHS community wellbeing officers group and share medical appointments, step care. I will just highlight I don't know if you've heard of the great work that New Zealand's doing in this space with Te Tumu Weora and its other better access work. This paradigm shift where they brought in health coaches and health improvement practitioners and social workers into primary care. And what they see is that there's a 3- to 5-fold increase in the access. People are being seen within 3 days most of the time. The providers are happy, the users are happy, far less prescribing because GPs aren't having to reach for the script to solve the problem in that moment. There are other ways of caring for people. And I'll just quickly mention, I love this study because it's about built environment design and it's so ignored. I am surprised at how ignored this is in mental health wards and unit design. We give people these huge plates, so of course they eat lots of food. There's very simple nudges and behavioural insights we can do to redesign our services, and it is ignored. I love this paper because that Stephanie Lidicott is an architect, essentially. So here you get medicine and different fields working together, which is exactly what needs to happen. So whether you see it like a Swiss cheese model or you see it like an onion ring, the point is building in these layers into a person's life to build that resilience, to build health and well-being, and thinking about where can we affect change. We can affect change at the individual level, we can affect change at the clinical level, we can affect change at the work, community level. It's very hard to affect change at the social level, so let's focus on where we can. So where to from here? So this is the question I get most commonly, but what do I do? What do I do? Well, I would just say, if you can, please practice this yourself. Start meditating, start doing your breathing exercises, do your stretches, you'll get through the groans. Because the positive feeling that is important, and we are burning out, and it's really important to look after yourself. The next thing is find your team, and I'll talk about that in a moment. And the last thing is, especially if you're a decision maker, you need time. We shouldn't be doing this at 12 o'clock at midnight in our spare time. Decision makers, executives, you need to provide time for your staff to come up with solutions and support them in that. I would just say here, thank you. I would just say here, when it comes to team, don't worry about the laggards and late majority. You guys are all the early adopters and innovators here. But find those people, find the other innovators and early adopters that you are working with. They are there. Here are some of the ones that I work with. I mentioned Scotty on the right there, who's the mental health nurse I work with, and some lads that we worked with in the community in the Aboriginal Health Centre who volunteered. These are the champions we've got to find. And I'll finish up, apologies for going over, but don't ask yourself what the world needs, ask yourself what makes you come alive, because what the world needs is more people who come alive. So thank you so much.